Welcome to Table Talk, the podcast series where clinical experience informs optimum human function. Today we have a very special guest, Dr. Danny Miller, a practice educator at the University College of Osteopathy, who has completed a professional doctorate in health psychology at the University of West England.
Danny's doctoral research project involves an exploration of how individuals can live well with pain and how an osteopath can be involved in fostering the process of living well. Through his further education, he can draw on a variety of health psychology theory to support behaviour change and patient-centred care.
Join us as we uncover Danny's insights into holistic health practices and the profound impact of his work in enhancing the quality of life of his patients. Welcome, Danny.
Thank you.
Thanks very much for coming on.
Thank you for the introduction.
You're very welcome. So tell us a little bit about your backstory before becoming an osteopath.
Wow. So I originally started off in finance when I basically left college when I was 17. You want it that far back, right?
Yes, absolutely.
Left college when I was 17, was firmly set on a career in finance. That was my aim, really. Got invited into it, and my dad said he knew someone, and then went on to started off in the futures market where you might have seen the shouting and the screaming at each other. Did that for 2 years, absolutely loved it. It was chaos, but really good, and then went into sales and trading and stayed at the same bank for nearly 15 years. Decided to retrain in 2008, and when the crash happened, I was like, oh, hang on, if this gets serious, I haven't got a career, I haven't got anything to fall back on. At that point, I had no real education, I had GCSEs, but nothing of really any value. Well, no, I shouldn't say that. I had no, kind of good GCSEs. And then spoke to my brother, who actually is an osteo as well. He qualified from here as well. He's working in Canada. And he said he'd done sports science. He said, well, why don't you look at osteo? Because you'll learn everything. I was like, oh, I'll do that then. And that was it. That was my thinking at that point. So I applied to here. It was the British School of Osteopathy it was then. Did the access course, then did the mixed mode course. So that was like 3 years part-time and 2 years full-time. Then qualified in 2016, practiced for a year. And I was like, something's missing. I was working with patients. I really got sucked into the manual therapy sucks movement. And I was like, well, what have we learned for 5 or so years? And just to say that obviously these are my opinions, right? These aren't any reflective of the UCO or the University of West of England or anything like that. They're purely my opinions. And I was like, well, what have I learnt for 5 years? If all this stuff isn't true, what am I going to do? How am I going to help people? But anyway, what I could never get away from, that manual therapy did help people. I always could never get away from that. And I just remember working with the patient, and he was like, I just wanted to fix me in 2 sessions. He was, family guy, and his wife was there in the appointment. She called herself the Rottweiler. She had some views, let's just say that. And I really didn't know how to handle them. They were very keen on behaviour change. They were like, I just want to lose weight, I just want to do this, just fed up of being in pain. But okay, fine. And I was like, okay, here's some ideas. Try this, here's some books to read, something like that. Here's just some clear points. We'll try these movements. And they were really set on it, like motivation, high. Saw them the week later. How did you get on with that stuff? What did you think? I ain't done it. And that there was that kind of early indication. How can you go from that high motivation to not do it? What was that link? Time was a barrier and all that sort of stuff. And he was in pain, and he had like lower back pain stuff. And I had this really odd reflection. Like I was working with him, I think he was sideline or something like that. And when I was working on his back, it was like it was like as if I had no feedback from him. There was no response from his body, and I was like, this is just odd. Question, obviously, reflect on my own skills, as I was like, maybe my skills just aren't there. They're just not right yet. And I couldn't get away from this manual therapy sucks idea. And even though I kind of like literally swung from the other way to, well, what am I doing then? And then I had this light bulb moment. I was like, well, maybe it starts with thinking. And then started looking at psychology. And then realised I had to do a psychology conversion course, and I did that. Started that in 2017, completed that in 2018. Masters in health psychology, and then on to the doctorate in health psychology. And when I got to the end of the masters in health psych, I was like, that's it. I can't do it anymore. And they were like, the careers advisors were like, well, why would you stop? That's like your stage one. Your next stage is the professional doctorate. That's the journey. I was like, oh, okay, well, I'll apply and see how it goes. Nearly didn't get in, because I had an interview and they were like, one was really for me being on the course, and one was like, well, there's no higher health psychology there. And the two, he told me about it after, they were like, well, there's loads of health psychology. He's working with people in pain. There's lots of psychology there. And that, so he, thankfully to him, he fought my corner and then got on the doctorate. And then it took me 4 years. So I started that in pre-COVID. So, and then finished. My Viva was on November 23 last year, and here we are. And then what timing, eh? I got announced the doctorate result this week. Like, you now may call yourself doctor. Fireworks.
I'm sure you've really been enjoying everyone running up to you and calling you.
I have. My ego has loved it.
I can imagine.
And I'll be grounded when I get home tonight to my family and kids.
Now the question is, have you had to correct anyone yet?
No, I don't know. I've got this really weird paradox, right? That I'm absolutely loving it, but I don't want to self-promote. And then, of course, I'm seeing all these things on like kind of LinkedIn, and I'm like, wow, this is amazing. And then, you know what it's like? You get sucked into these things. No, just because there's a process. For me, it's always been about it. I've always enjoyed the process. That I have focused on the outcome a little bit, but I've always enjoyed everything I've done in the psychology bit has had a direct response on the people I work with, without a doubt. So I've always had, there's not been a lag time. There's been, right, okay, I read something and I'll try it. And I can write about it in two different things.
So what exactly is health psychology? I think we have a lot of listeners who don't quite understand what it means.
Yeah,
I was wondering if you could talk about that a bit.
Psychology is the study of behaviour, or the human mind, or study of behaviour. You obviously get clinical psychology, which might be more focused on the severe mental health, like obsessive compulsive disorders, schizophrenia, suicidal ideation, real kind of serious stuff, where health psychology is an important distinction. Of course, all that's going to be there, or to some severe extent, but it's going to be like, for me, it's like the behaviour related to a chronic health condition. So you take pain, for example. If people had long-term pain or in pain, it doesn't make people feel very good. So they'll change adapt their behaviour, they might avoid, and then of course then that you might get some type of mental health thing, depression, possibly anxiety. So for me, health psychology is supporting the health-related behaviour. So like a behaviour change aspect.
It's almost like applied psychology to some degree.
Exactly that, Brendan. Yeah, okay. Exactly that.
Cool. I know you touched on your beliefs around like manual therapy and things like that. And how do you kind of integrate this health psychology element into your osteopathic practice?
That's a good question, Brendan. I had a real conflict when I started, like with myself, an internal conflict. I was like, if we don't know what's happening underneath our hands, and the real evidence says there are some physiological effects, we don't know what, but there's a load of other factors. There's contextual factors, the way I am in a consultation, the environment that they're in, the patients mental health at that time, how they're feeling within themselves. How can I use that? And so I kind of swung one way to realise, well, there's no point then, to like, oh, hang on a minute. Whatever people go and see, whether it's an osteo, a health psychologist, physio, chiro, you name it, sports massage therapist. You think, if you Google I'm in pain, who do I see? You'll see a list of stuff, right? There's elements in there, regardless of whether it's evidence informed, people still respond. People will still have, it might go against the evidence, but people will say, I feel better. I could never, ever get away from that, ever. So, rather than me using manual therapy to say, change certain aspects of the physiology, I use it as a way to engage with the person. So while I'm using manual therapy to have an effect on pain sensitization or something, I'll be engaging with the person. So that's when I draw on the health psych stuff, look at some of the acceptance and commitment therapy based, look at values. That for me was big. Look at internal motivation, look at self-efficacy. And by that, I'm not obviously going to say, oh, how confident do you feel in this process? For me, it's understanding what behaviours, or whatever that may be. It's not exercise, doesn't have to be exercise, just something where they do something and put a smile on their face. That's it. If I can understand that and then focus treatment and manual therapy around that, then the evidence says that they might have a good outcome. Alongside everything that I am as a person. How am I feeling that day? Am I engaged? Am I feeling all right? What's my reflection like on myself? So all trying to really flood the room with contextual factors that I can control. I can't control their response, but I can control my behaviour and my responses to pain.
That's so interesting, because you realise how patients often, I guess the patients that we see, at least in this student clinic, I'll just talk about that population because I guess it's quite specific, but a lot of the patients that we tend to see don't think in terms of values. They think, I'm in pain, take it away. So I was wondering if you had any ways of approaching those kind of conversations based on the research that you've done on living well with pain, how to approach those better as clinicians with patients who actually don't really have like a functional outcome that they'd like to achieve.
So how do we support people who are just in pain and they can't do anything? So that dichotomy. I don't think there's an easy way. I'd love to be able to say, I'll do this and it all goes away and it's fine.
Yeah.
I think you just give yourself time. Always give yourself time. I think historically it was like 2 or 3 treatments and they'll be fine. But what happens if they're not fine after 2 or 3 treatments? And even that, sometimes it's just really trying to explore their understanding of what pain is to them. And they're tricky conversations to have. They're not comfortable conversations. You know, especially what does pain mean to you? It hurts. It hurts and I can't do anything. And it's like, okay, and that's, you know, you hit with that kind of like, you know, if you look at models of change, you hit with that. No, there's no room for manoeuvre here. And that's where they're at that moment in time. So I don't think, what I've realised is you can't force it on someone. I can't force my opinion and my beliefs of pain on someone else. If they're in pain and that's how they see it, that's where they are. They're in pain and they can't do anything. So that's where I suppose where the assessment side of it comes into it a little bit. Let's look at what you can do. Let's not focus on your restrictions. Let's not focus on your weaknesses. Let's not focus on what you can't do. Let's just, however small, let's focus what you can do now, and then we'll build it up from that. And then it still might collapse.
Yeah,
go on.
So I guess you're meeting the patient where they're at, which is like a vital component of being able to have success in your treatment outcomes. And now I know you mentioned about maintaining control the factors that you're able to control. So how do you go about kind of making sure you're bringing your best self into the treatment room? Do you have something in place? Do you have a protocol? Do you have something that you do?
So I do a lot of like meditation and stuff. So I use a lot of meditation practice, just like breath. If someone's not understanding something or someone's not, kind of just putting barriers up, I have to try and separate myself from that. Like, that's not my fault. You know, okay, there's some of it might be if I've used they've misunderstood a term of mine, but I give them the space. So silence is a massive thing. You know, watching them process it and making sure I'm all right with the silence as well. You know, as you see someone thinking about something. And then I think it's a big reflection-based thing for me. You know, like I'm trying to just think of like meditation's a big one. Movement in myself. You know, I enjoy doing movement. And I always believe that, and this comes from my own research as well, like I fundamentally believe someone has the right to live well. And however that may be for them. You know, I just... that, and it comes through all my personal reflection stuff. Like, everyone should have the chance to be, you know, everyone's going to experience pain at some time of their life, and sometimes that's hard to understand. You know, some people say, just get rid of my pain. So, right, then we were in that dichotomy again. In pain, I can't do anything. When I'm in no pain, I can do everything. And it's about understanding that middle ground.
Yeah, it's interesting what you said about silence. There's a lovely book called With the End in Mind by Catherine Mannix, and
right.
I'm not sure if you've read that one, but it's a wonderful book about dying. And one passage, she explores the use of silence in clinical encounters, and how even if it might feel like silence to the clinician, it is not silent for the person who's working through that in their heads. And kind of having more of an awareness of that, I think, can be really helpful to give people that kind of space that they might need to process
and
things.
it's hard when we're students because we feel like we've got to fill the room with noise. So we talk, we rabble, all that, and I've done it loads. You know, this person needs to hear what I've got to say. But they don't. Sometimes they can work it out for themselves. And it's the smallest of things. You know, which I'm a big fan of. Like, if someone has a really good response, a really, like, you know, like, well, that was a bit unexpected, like, in a positive way, like, always ask them what's changed. What do you think has changed? In the last week, you've had a really good response to treatment or a good response, your pain's dropped a lot, you've engaged with something. What has changed? And you never get the answer you think you're going to get.
What kind of answers do you usually, have you found that you've got to that question then?
I think it's been things like, you said this, so you told me I was going to be all right. So I've done something and I felt better, and then I reinforced that behaviour. I very rarely, if they say it was the treatment you did, I said, no, it's probably going to be something else. I very, very rarely say it's the treatment I've done. And I think I spoke to you before about that, Romy. It's like, if I'm in the treatment encounter and I see treatment as supportive rather than changing tissue and all this sort of having a physiological effect, but you have a sensitisation effect on pain, possibly. But if it goes well, I can't take responsibility for it. But on the flip side of it, if they have a bad response, I can't take responsibility for it. So I've got both sides of the coin there. So if it does go bad, I'll ask the same question: what do you think's changed? You know, because it's always interesting to understand. And then it's a reflection point, because then it's, okay, well, have I misunderstood something? So then I reflect on it myself and say, okay, what have I missed? Is there a further course of management that I need to do? Or something like that.
So you're not necessarily removing yourself from the responsibility, but it's more the treatment is not the focus of your outcomes.
No.
But you're still taking responsibility regardless which direction it goes.
And
right?
you think, right, the treatment room is organised chaos. It is organised chaos, right? You've got the morning you've had, or the morning I've had. You know, I could have had, you know, my kids could have thrown breakfast over me or something like that. It doesn't put me on a good footing. then I could get, you know, I could walk outside, step in a puddle, drink my coffee spilt all down me. Now I've got like severe, like, I don't want to say anger.
Agitated.
Great word.
Nice.
Mental anguish. Unsettling.
Coming from a place of knowing.
Yeah, right? So not only that, but then you've got whatever the patient's going to bring. They're in pain. You know, it's like only for... And through talking to people in pain and reading stuff about the pain experience, people can't put it into words. You can't. You look at these things and go, okay, it's burning pain. It's this pain, so this means it's neurological. Or it's this type of pain, so it means it's this type of injury. That's a medical definition, and that's a medical term. Patients will not. Well, they might do, but they tend to explain it in forms of sentences or metaphors or stories or something like that. So if I'm already a bit wound up, and then the patient's really wound up because they're in pain, you can kind of see how it gets a bit chaotic. So I've got to settle myself down. But like, well, you know, in a way, if the patient's in pain, like you said, Brandon, we have to meet them where they're at, and they're going to explain it in whichever way they feel necessary.
So what have you found living well with pain can look like? Maybe in a patient that surprised you, or patients that surprised you maybe after a treatment encounter, or actually through their own sort of, I was going to say self-management, but you told me a wonderful term.
Collabament.
That you can go into in a second. Yeah, I was just wondering kind of what you think living well with pain can look like in your experience.
That's such a good question. I can only really base it on the participants that I interviewed. For them, they had a real backstory, and you can't define living well with pain without understanding some type of their past. It wasn't a case of where they woke up and gone, I'm out of pain now, I'm going to decide and do whatever I want to do today. It was never ever that easy. There was in three of them there was history of traumatic experiences, whether it was bullying, family history, traumatic, like working stress. There was a whole host of things in a few of them. So they'd really gone through it. And there's one guy, he was in his 60s, and I'll never forget it. There were actually two instances that I remember why. This guy said it got to a point where I spent 6 months in a chair and I was scared to move. And I was in Dublin and my wife was literally watching me to this chair, tied to a chair, and she was concerned. Another person said, what did they say? Oh, what was I going to say? They described pain, it's like being eaten alive. And they said, but the interesting thing is, they said to me, do you know what that's like? I can't respond to that. You know, and part of my reflection is, thankfully, I'm not in any pain or anything like that. How can I ever say, oh yeah, I know what that feels like? I don't. But the language is very descriptive. The other guy was like, you know, it was going to be, he didn't say it directly, but the way I interpreted it was like, he didn't see anywhere else to go. He was in Dublin, it was dark, it was cold, he was smoking lots of like hash and all that sort of stuff. He was very open with what he said. But he said he saw the look on his wife's face. He said it was just, you know, this look of concern, this look of worry. And it was like, why don't you try an osteopath and see how you get on? And he was like, all right, I've got nothing else, there's nothing to lose. And that was the trigger point for him. So it was like a trigger of change. And there was another guy that said the pain of changing was far worse than the pain of staying the same was far worse than the pain of trying to change. There was like a key points in their story. There was like, I'm done. Another person was, I finally realised that I could heal, I could be out of pain. So that's where for them living well started. So it wasn't like a case of, and for them it looked like it was in the early days a real trial and error approach, realising they could relieve pain themselves, realising they could do the stuff they enjoyed despite pain. So for them, and some of them took a spiritual approach, some of them took an exercise approach, some of them, you know, took exercise and spiritual approach. And by that I mean, you know, meditation or breath work or something like that. Not just spiritual, is probably a bit too broad, yeah. But, you know, so living well for them was something that they'd nurtured. It wasn't something that, you know, for them, I think I defined it as living well, pain was living well and doing the stuff they valued despite pain. They realised that they could live a valued life. Osteopathy within that was kind of like, was seen as more of a supportive role. You know, and they think it all comes with a history. So their experiences behind that, they'd felt like they'd been gaslighted by the medical industry. So one guy was like, I'm chronically fatigued. And the GP said, well, your blood tests are fine. So you're like, what's wrong? So he always felt dismissed. And then of course you get coming to an osteo appointment, that's what I had to be really careful was saying, oh, this is all osteopathy. So osteopathy's great. But it was just so happened they turned into osteopathy. It could have gone, and one of the guys was right. He said, I could have gone to any practitioner and I was ready to change. That's the thing. So that comes into that internal desire, internal motivation, willingness to try different things and all that sort of stuff. So living well for them, right, it's hard to say what does it look like. But again, what inspired me even with working with it, they just had this sense of like, compassion for themselves and kindness. They were quite happy to say no to things where before they would have said they had to do everything, they had to like impress society, and now they don't feel they had to do that. So they were much kinder to themselves. Not only were the behaviours seen as healthy, they were also, their internal narrative was very different.
It's interesting what you said about time earlier. Sometimes we need to respect the time that things take to sediment and to shift, and you might have the same conversation with someone at various points in time and they will have no response, and then one day you'll say the same thing, maybe in a slightly different way, and like you said, they're bringing their environment with them on that day that's maybe a little bit more open. Today. I'm thinking about literally that patient, and then you say something and they go, oh yeah, I can hear you now. And then the changes can be drastic and instant, but they need to be ready to hear it.
There's a model called the Trans-Diagnostic Model of Change. It was set up for addiction therapy. So they would like, you know, so people going into therapy or something like that, they would say, what, you know, there's like, what is it? Contemplation, pre-contemplation, contemplation, action, maintenance, something else. But if they're in the pre-contemplation stage, they've had no thought of changing within the last 6 months. So of course they'd get asked that question. Have you thought about stopping drinking or stopping your addictive behaviour in the last 6 months? No. Okay, well, why do we need to force change on you? They're not ready. So then obviously, but then the people are like, yeah, you know what, I have thought about it in the last 6 months. I'm really getting a bit fed up with the consequences and all that. I think I'm ready, or I'm willing to give, and that's that pre-contemplation stage. The action stage, yeah, I've actually actively tried to stop within the last I think it's 3 or 4, it might even be sooner than that, 3 or 4 weeks. We can apply that to people we're working with. So you can say, how confident do you feel about using this behaviour? Or how confident do you feel in trying this different stuff? No interest. Okay, fine. If you're not ready, you're not ready. We can't then say, okay, well, try this, try that. Why don't you do this? I think this will be really good. But if they've tried something in the last 6 months, and I think you found that today, Remy, that they'd kind of started engaging with the patient a little bit more. They were more willing to listen, then this happened. Yeah. And it could be down to any number of factors, right?
Yeah, it's interesting. It almost requires a certain level of like activation energy to shift from that initial first phase to the second phase before you can even begin to bring action into the equation.
Yeah, and I think this is where sometimes, and I say we as in we push it too quick. Do this, this is going to really help you, blah, blah, blah. Then that's coming from me, right? That's me suggesting a practitioner, expert approach. And, you know, when I reflect back on it, I was quite like that in the early days. Do this exercise, it'll make you feel better. Not even understanding what exercise means to someone. You know, I assume in those early days, exercise is the best thing ever. But yet no one does it. Well, that's a really bad generalisation. I suppose in rehabilitation terms, movement is seen as a good thing and to support recovery. Yet it's home-based exercise to follow is the most poor. I can't remember the stat or what the actual line is poorly adhered to.
Yeah, I think generally if I prescribe an exercise to a patient and I prescribe a certain rep range, set amount, whatever it is, I expect 40% of that when I give it out. And it's crazy that you'd think that even giving that exercise, even if you think that it's going to be appropriate and it's going to help the problem, but you're expecting a less outcome than what you're achieving for, which is crazy. Could you provide a little bit of an insight into the research of living well with pain? Kind of what does it mean to you personally, and then also kind of what have you found?
Good question, because I did have my Viva. So it's hard to start. I need to give you a bit of context. So I was always interested by the others, like the positive experiences of something. I was always fascinated by that, and through the psychology training and all that sort of stuff, I was lucky enough and fortunate enough to observe recovery meetings. So I was fortunate enough. And what I was absolutely inspired by, despite the horrific consequences, the horrific thing that addiction does to people, to their individuals, to their families, to their health, to everything, in these recovery meetings, people were really accepting of it. Like, I've got that, I can't change it. I can't drink alcohol, I can't take drugs safely, I can't do whatever it is safely. Yet, in these meetings, the energy was another level. I was like, what's going on here? Like, when I first walked into these recovery meetings to observe them, I was like, everyone's going to be looking at the floor, grieving over the fact they can't drink or do what they deemed as excitement. They can't do it anymore. The opposite was there. They were buzzing, right? I was like, what's all that about? So I was inspired by that, like really, really inspired by it. And it kind of then, as you know, it happened, I'd working with people in pain, and there'd be like, and some of it even here, people with real long-term health conditions, and you'd see them, and you'd say, how are you getting on? I feel great. I've had this appointment, I've had that appointment, I'm like, the evidence was quick to tell us about the negative experiences of pain. Like, you know, it has this effect on depression, it has the effect on anxiety, it has this effect on our body, blah, 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 blah. But then you've got this other group of people that are living despite a condition. I was like, what's that about? Like, what can we learn from them? Like, you know, there's countless qualitative research on people's experiences of pain. And it will be the negative sides of it. And like, you know, there's some papers, there's reviews about it, you know. But then you don't tend to see much about the recovery aspect. So I was like, what can I learn from them? How is it, what can I learn from what they've done to then maybe suggest to people who are really in the thick of it? Hope and resilience, positive like effects. And then there was a really good, real chunky piece of paper. Like, I mean, it was like 300. It was like, well, it was a book. Like, and I can't remember the author's name, but it was like a neuroscience approach to resilience or something like that. And there was one sentence of it. Current psychological models will focus on the negative valence of pain. What about the positive valence of it? I was like, there you go. So that's when I started like looking at this idea of living well. And even you may have come across Bronnie Lennox-Thompson. She's an occupational therapist in New Zealand. Really cool stuff. Like, she just said, what is living well with pain? Or living well with chronic pain, I think she called it. And I thought, well, I better tag in the osteo to make it a niche, right? but it had a direct impact, right? That was for me, that was how it had, how I could bring in my osteopathy experience and then apply it to psychology. And so that was really it. Like, I wanted to find out about that stuff. And then, so the research method I use is like phenomenological analysis, interpretive phenomenological analysis, really understanding lived experience. So I didn't need that many participants. I had 5 participants, fascinating people like to listen to. Like, the interviews were probably an hour and a half, but I think the analysis took me a year, like just like 2 a day, not every day for 2 years, like a year, but, like really getting into like what they're saying, the language they're saying, and just like, I was so grateful for what they shared with me. They didn't have to get that real personal and really try and involve me in their experience. They didn't have to do that. And they did. They were really open with their experience. But yeah, like, and then going through like hearing their change, for me I found it really inspiring. Like, really inspiring to see. So for me, there's always that element of hope with people. That's what it's really helped me with. There's that element of hope. If people want to hear it. I don't like preach.
Yeah,
because that was the finding from Dr. Frankl's book. Is it the meaning of life?
Yeah, that's a good book.
And that's the commonality between, like, essentially it's really living well with pain, really, right? Is hope. It's the biggest compounding factor across the board as to the outcomes of the people that were in that position. And
that's what they had. They developed hope. So the findings for me was obviously. I can't remember them word for word, and I don't want to sell you short, right? So it was like, oh, here we go. So there were 4 key themes. So the common one, obviously, was living with pain. It was exhausting. Like, we know that, right? You see it firsthand in clinic. That you see people coming in pain, haven't slept, they're scared, they're fearful, they've had to start withdrawing for their, you see it in their face. But what was interesting for me is they could clearly remember their first experience. They could articulate it. They could take you back to the day they first experienced pain. Like, one bloke was like, I remember I was 14, I was 60, I was 14 years old and I woke up with neck pain. Couldn't move my neck. And then my mum suggested I go and see someone. But he was so clear. Same like, what was it? One of the other participants. She was like, it all started when I started seeing like my wife, my partner. My mother going through cancer. Just like that real horrible experience. Guy, remember, I was getting bullied, and I wasn't getting bullied at the time, but then I was like, I think I was doing a press up or getting up from a rugby scrum, and I felt something go. So like, it was like the memory. It was like it was yesterday. And I was like, that's mad.
It's interesting how pain can also bias your memory, or at least maybe trauma as a broader term. We see patients sometimes, I can think of one in particular where everything she's mentioned can be traced back to a date and an event. And it's like, did you have these symptoms before? Oh, no. And it's almost like her life started, or at least her pain person started on this day, and nothing ever existed before that. And you start to really see how people's identities become so intertwined. This is why I really like the phrase living well with pain and not living well despite pain, because it's part of them. And like you said, constantly trying to find the lesion or
the reason,
the imbalance or the asymmetry or whatever it is almost negating the fact that the pain is part of them, and we need to take it as a whole package and not try to dissect the two. I was wondering how you found this research that you've been looking into, and this, I think it's a relatively budding trend in osteopathy, how you found other osteopaths have received this, because it can go against other schools of thought?
Well, you know what? I've not been that public with it.
Okay.
So, and this is, I'm kind of debating with myself. Do I start going down the publishing route? And, and the examiners are like, you should do something with this. And one of them's like, how can you get it to the most people? And they're like, maybe you should write into the psychologist or something like that and do a piece for them. And I was like, okay, you maybe, but I'm just like, mate, it's a bit too soon at the moment. The last thing I want to start doing is writing more, or just drawing on my research and stuff. But stuff like this is very useful, stuff like this is very useful. And the people I work with at Pure and at Phoenix Osteopathy, very receptive, really receptive to understand the different and how we kind of get that from people, which is great. And I think it does. It adds a different type of feeling to the encounter, because if you understand that if there's that glimmer of hope, and the patient might not recognise it then, they might do, they might not, right? If they just see there's just that slight chance, then maybe that's enough. We don't have to force it, but we just give them the opportunity. And so I've had conversations with, look, I did this research. You're describing a really similar experience to a participant I spoke to. And they did this, and now they're living a valued life. It took time. It didn't happen overnight, but they started trying different things, and they started doing this, they started doing that, what they thought was enjoyable, and then they started to change. Not overnight, it took, and this is the thing, it took them years. And that's the thing, they're very open to the understanding that when I'm in pain, I have to be kind to myself, but when I'm out of pain, I know this, they call it pacing is the term. I don't overdo it. I don't try and be everything to everyone. I say no to stuff. No, I was saying earlier.
And do you ever find that by trying to initiate these conversations about hope, if we use that kind of broad term, do you ever find that there's resistance from patients who feel like that might be invalidating their experience by asking them to focus on positives rather than,
I think again it takes reading of the situation, because you know what it's like. You don't want to give false hope. Yeah, I think that's horrible. Again, it's all based on whether they're a bit curious about it, where they stand. If they're like, all of a sudden I'm in 100% pain, probably wouldn't have the discussion then. If they genuinely look rubbish and they just look down and they're just in it, then maybe now's not the time. But I think it was William Osler, right, back in the 1800s. I'm sure he was like the person that invented person-centered care. He always said, whichever it is, just leave the room with a little bit of hope. That's it. Just a little bit. And that was he was around the same time as Andrew Taylor Still. They never met, but, they were around similar times. And he's like, unbelievable. Some of his work is just crazy. Like some of the stuff he's writing about back in that day. Yeah. We're saying, this is all new stuff. This person-centered care and all this is not. Yeah. This was he's talking about this in the mid-1800s.
And there's another lovely saying of his that I always try to think of is, listen to your patient. They're telling you the diagnosis. And even not thinking about diagnosis right now, but the whole thing of listening to the patient to really gain an insight into what exactly is going on a diagnostic level, but then also just a whole sort of their kind of entire universe, I guess, their personal environment, their external environment is wonderful. I think listening, maybe, like you said before, we try to spew all of this stuff at patients and throw them as many tools as we can, maybe from a place of feeling kind of incompetent and hoping that at least one thing's going to catch, right? But it definitely seems like listening is very underestimated. We should do it a bit more.
And again, Peter O'Sullivan says it. I think a few of the people who have done obviously loads of work in pain, they will say you'll get the nugget in the first 5 minutes. You'll get it. You'll get why they're in pain or what's happened or their understanding of it. But it's a skill, right? You know what it's like. If we give someone 5 minutes over the road, you might not get them out. Because you're scared to stop, and I was guilty of that. Like, If someone's really into their story, at what point do you say, right, now's the time to ask you about aggravating and relieving factors? But yeah, that's stuff, but it depends on where that person is. And that's the thing, I think it's as well giving you the freedom to try it. And if they respond badly, it's not a tool to beat yourself up with. That's it, your clinical career hasn't collapsed because you've upset someone trying to do something.
That's so true.
And actually, even we've touched on so many aspects of other people's stories of kind of pain experiences, pain beliefs, but how do you kind of define / what are your pain... How do you define pain in your own words? Like, what is your understanding or belief of pain now? You've kind of have this research under your belt, you've treated many patients, all of these kind of things. What does it mean to you?
Me, personally?
Yeah.
Wow. I suppose it depends on when you ask me.
Is that before or after dinner with the kids?
Yeah. I keep going to the academic death of the IS this, it's like suffering, it's, there's no real cause. Or, these tissue pain with or without cause, but that's the academic death. I think for me it's like, God, what a question. I think it's like personal suffering. Real personal suffering. Again, it's not my opinion, I'm just getting it off the stuff I've read. I think it was someone, I can't remember who said it, I think it was a philosopher, said pain robs everything but itself. That's a good one, isn't it?
Is good.
That's a good one.
I think you answered that question.
Yeah.
But it's, you know what I mean? It's hard to say, give that definition of it. You're the best person to get, I can only get it off of my experience of working with people. I've never ever had to wake up and go, if I move my leg, what's it going to feel like? If I get out of bed, what am I going to be able to carry on my day? Or do I have to go back to bed again?
And it's this very strange, invisible thing that we spend our days trying to understand and manage as clinicians, and then the patients are trying to also understand and manage in their own ways. And it's such an interesting thing that we don't know what it looks like, we don't know what it feels like, because we know that everyone's pain is subjective, and yet we're trying to manage this thing. And it can be so challenging at times to kind of make sense of it and know how it behaves, because I guess everyone's pain is like a different personality as well. I
was reading this thing the other day. It was about scans and all that sort of stuff. And basically it said, you might have all those findings on scans, disc bulges, osteoarthritis, all the stuff. And you go, but you can't see pain. I was like, that's so true. Like, you can see a scan and you go, that person must be agony. And you see them, they're jumping up and down the street. Can't see pain. I was like, it's so true. And I've read about similar sort of stuff in the qualitative literature saying it's the invisible illness. If you could see me, I'd be black and blue. And it's so, and even in my research, they were like, how can I explain to something that they can't see?
Right. It's the eternal challenge.
Yeah, if I've hurt my just that arm, and I've got a bruise, and I've got a cut, and I've got trauma, I can say this hurts here. Which is then when you start thinking about the value of like pain scores and all that sort of stuff.
And dismissal that some patients with chronic pain conditions can face, like you said, the sort of gaslighting in the medical profession that can happen sometimes when we can't see what people are experiencing.
And you're not seeing, and they're seen as malingerers, treatment seekers. And there's this really interesting term. I'm going to get why do I have to guess? I've got it wrote about in my paper. I think it's called epistemological hierarchy.
Is it out yet? Your paper?
It's live. It's on the
Really?
UE repository. Yeah.
We'll put a link in the in the description.
If you're having trouble sleeping, there's a few bits to get through.
Okay.
But her name's Javi Carell. She writes all about this stuff. She's a philosopher. She's done work she got diagnosed with a long-term lung condition. The way she writes is just, it's just brilliant. She talks about epistemological hierarchy. I think she talks about epistemic injustice, or epistemic hierarchy. Okay. So obviously I don't want to generalise, right? But in some instances, there's that social hierarchy within a medical encounter. So there's like, we've done all our training in pain, we've done all our training in medical terminology, and then the patient never ever explains their experience in those terms. It's going to come out as a mess of emotion, of beliefs, of chaos, of a incoherent story, which then, of course, if we can't, then we've got to be careful that we're not guilty in saying, actually, their story's not making sense, so it's not real. So we have to be really careful, and that's why I was talking about that kind of terms like gaslighting and stuff that they experienced. Like, you're not presenting as you should be, so your experience isn't real, or you shouldn't be feeling those. What you're not feeling this because it's not showing us on scan, or it's not showing us on your blood tests.
Yeah, because there's a very interesting poster downstairs in one of the rooms that has the statistics. I think it's from 2010 all the way through to like 1990 of the statistics of the symptomatic presentation of an injury, whether it be a disc bulge, a rotate. I think that, if I can remember off the top of my head, I think it's, if you scan everyone's shoulder over the age of 60, the rotator cuff specifically, is 70% will have a full thickness rotator cuff tear that's asymptomatic, which is insane. And if you think about how many people actually are dealing with shoulder pain and then go get a scan and it's not showing,
and you
that's
think
not presented,
and that's where we got to watch our reasoning process. We only see people in pain. People don't come to us and say, I'm in no pain, I feel, well, some people might, can you just help me with something? But we only see people in pain. So if someone, and I'm guilty of this, if someone's got a shoulder slightly higher, just use a general term, right? A shoulder slightly higher than the other, or a slightly elevated hip, or something like that, and I only ever see people like that in pain, I'm going to say, it's because of your elevated hip. Or it could be a factor, right? And I was guilty of that when I was a student, and even early days in practice. But then if we think of that study, then there could be people with all those sort of imbalances, but in no pain. So I think we have to be careful that, obviously we see people in pain. If we see people with similar build, gender, identity, they could experience no pain. And I think then I was like...
And so how does illness beliefs then come into the equation? And how does it kind of impact treatment? And I guess treatment outcomes to some degree?
Well, illness beliefs.
Illness beliefs, pain beliefs, umbrella term.
It's a hard one to unpack. Maybe I might pick it more up in fear avoidance.
Yeah.
So like, I can't do this because of this, or I'm scared of doing this. Which then you could obviously see how that's going to impact behaviour. And in a way, that's where I think, actually, it was Danny Orchard's tutorial earlier, he was talking about that graded exposure stuff. We grade someone into their movements. They start small and then we build up to it. So for me, I suppose it's challenging. And I think even now, oh God, I don't want to do it. I don't want to say the wrong thing. I think it's like predictive processing. I mean, Ollie talk about this a lot, where you try and create a prediction error. So
I think it is, yeah.
Yeah, so we try and get them to do a movement and they're expecting pain and they don't. Like, I wasn't expecting that. So you create that prediction error. So a lot of that's how I kind of work with it. Doesn't necessarily mean it has a great effect on outcomes, because you think then all of a sudden they're going to go back to their environment, which then has a whole host of differentiation. There's all those contextual factors that we can't change. And I remember once, I think I'd qualified, I hadn't been qualified long, and I was associate clinic. Basically, if you newly qualified, I couldn't recommend the associate clinic enough. Like familiar surroundings and all that sort of stuff. The reception team are brilliant. You're going to get patients. Anyway, shameless plug. But I recommend it. And I saw this patient, she was a runner. She was like, my knee's really sore, I don't want to run. I was like, okay, well, what's stopping you? She was like, just knee pain. I was like, okay, well, when was the last time you ran? 6 months ago. Well, why don't we give it a go again and see how you feel? Are you sure, this is how it starts? I said, well, look, it's been 6 months, your knee's moving fine, you've got good power through your knee, you're able to do these movements, why don't you give it a go and see how you feel? And she was really excited about it. And then she went home, and this is obviously, I found this out the week later. I said, how did you get on with the running and all that sort of stuff? Well, my husband said it was when I started running with knee pain, Surely I shouldn't start doing it again because that's what caused the knee pain in the first place. So she didn't go. So you can kind of see the environmental factors. So it's not, or they see something, especially, your social media. So, there's so much information now. We've got, and you can kind of see the effects of advice, really, and sometimes dangerous advice.
Yeah, because we're really in an age of misinformation. There's a lot more of that than there is of useful info that we can kind of apply.
You look, it's the 3 exercises to fix back pain.
Exactly. Yeah.
If that was simple, if it was that simple, we probably wouldn't be having the issues that we're having with pain.
And we wouldn't have a job.
Exactly, yeah.
No one tell them what the exercises are.
You find that when you qualify, we tell you all that when you qualify. To keep you in. So you don't leave early.
It's all a scam.
But, again, it's all about, and this is the thing, it's like, it's always trying to now reflect on what the patient says and get them to understand it for themselves, because sometimes that's what I think that can be an issue. It's where they're having an issue with making sense of it, and we're there to support them through that. And that's like the inactivist model and all that sort of stuff. Then it's just like, is there a breakdown in sense making? And then we can is there something we can help join the dots with that? Dots. Is there something we can do with that? Because if you think, if we apply a biopsychosocial model, and it's like, we've got obviously the biopsychosocial, are we then quick to silo patients off into one of those 3 things? So one of the big critiques of the biopsychosocial model, where the inactivist model says there's no boundary. Is it there an issue they're having with their environment? How can we support them getting back to that? Then it completely opens up, as far as I was concerned. Because then it's just being supportive, it's being curious about them as a person, it's reinforcing their values, which again it doesn't have to be exercise. You think of some of the people we see here, they're busy, they might be in complex housing, they might have maybe single parents or something like that. If we then say do this exercise without understanding their environment, and then we're then quick to blame if they come back and say they haven't done it because we haven't understood their environment. If we're encouraging movement and exercise and they live in a really a block of flats that they can't get out of and they're scared about going downstairs, what's the high chance of them doing something? But they might I just want 5 minutes to myself, and you work to that. So illness beliefs, and pain beliefs, again, it's personal. What might be a really fearful, painful illness belief for one person might be a completely and utterly positive factor for another.
It seems like this path within osteopathy or within healthcare seems to be maybe a difficult shift for some to make, because it means moving away from some of the heroism that comes with certain practices. Yeah. And those are I feel like the paternalism side we're more aware of it now, but there's also still kind of, in some parts of the profession, I feel like there's a sense of heroism, as in, I did that technique and now they can walk without a cane when they leave and that kind of thing. And maybe detaching from that can be quite difficult as well, to think actually it doesn't have anything to do with me at all.
It's that question, isn't it? We spoke about it, and I spoke about it with a number of people in the team point. Well, what do I do then?
Yeah.
What's the value in what we do? I said, well, there's a lot of value in what we do. Loads of value. Just because we're not applying a certain technique doesn't mean that we're worthless as a profession. I think we've got I think when people say there's no evidence for osteopathy, it's poorly researched, blah, 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 I think, no. You're just looking in the wrong spaces. It just might not have manipulation in the title. It might not have osteopathic technique in the title. It might not have the soft tissue massage in the title. But you look at all the work done on Therapeutic Alliance. There's plenty of stuff there reinforcing what we do. Case history, giving someone time, validating their experience. There's plenty of evidence around. Just because it hasn't got osteopathy in the title doesn't then mean that we're poorly evidenced. We can do a review on it. Probably is reviews on Therapeutic Alliance, and in fact there is. I think Steve Vogel did something on it. Therapeutic Alliance, or was it on something cognitive, something else? I can't remember. But there's, what I mean. There's loads of research for what we do. It's just we just look in the wrong space. We just you know, we don't. I don't think we look at sometimes in the right places. And then of course you have social media that massively magnifies it.
And again, thinking not only about exploring people's pain beliefs, but exploring the resilience that we can find in that. There's some really interesting research on adverse childhood experiences out there. I can go on about that for ages, but the main point of that I've found in some of the papers critiquing the ACE model was that we're not using it in conjunction with positive childhood experiences, which have been proven to be a physiological buffer against the effects of toxic stress. And having that awareness of balancing the trauma with resilience and seeing both as valuable and mutually intertwined is really interesting.
That reminds me, actually, there was a really cool paper out that someone in the positive psychology paper shared with me, and I'm probably using this right at the wrong point because now I can't remember the name of the paper. I think it's like post-traumatic model, where it says exactly that, and it kind of fits with my research as well, that people have these traumatic experiences and then out of it becomes this, they get very resilient. It's a process.
So how do you find that your own beliefs have had to change when working with these people? How have you managed to kind of reduce your prejudice, I guess, in certain ways? Are there any things that you've done to work with that?
It's been a real non-judgmental practice. Like if someone's going through their experience, I have to be really, and this is, I was really guilty of this in the early days. Oh, what do you mean you're in pain? You're doing all this sort of stuff. Total, like invalidation of their experience. And then this could become a real non-judgmental thing. That's what they're going through. That for them is their personal experience. It's, you know, they're coming to me for help. Who am I to judge? I can't make a judgment. I don't know anything about their life. You know, just as a side note, right? You think, right, what we do is bonkers, right? You think about it, right? And this is, I only ever reflected on this after I qualified. Sorry, I'm going to go off on a tangent, right? Go. Right? You just think, right? Obviously, a practice educator, teacher, whatever you want to call me, you guys are students, right? I'm expecting you to come out after 40 minutes understanding their pain experience, their life, what they do, their valued activities, blah, 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 and summarise it in 40 minutes. I was like, that, you know, only afterwards I was like, that is just insane. It's just, when you think about it, you know, when, you know, the more reading I've done on pain, on people's lives and all that sort of stuff, I think sometimes as well, we discredit what we do. What we do is mental. Like, understanding someone's experience and trying to help them in minutes. That's what it is, really. You know, when we're blessed with time, GPs don't have that luxury. And we've got an extra 20, 30 minutes.
Yeah, that's true.
I just think it's nuts.
I mean, it is nuts, but there's some beauty in that, right? That it's like a deeply complex problem-solving activity.
Yeah.
And then I guess that's also why we don't expect to be able to cure someone of those symptoms within one session. But you'll get to know them over 10,
period of time,
12, and if especially with a chronic pain presentation, there might be 6 months, there might be a year, there might be more.
But I think that's where we need to be kind to ourselves as people.
Absolutely.
To realise that if they don't improve or we don't have the outcome that we expected, I don't think we can be to say that we're okay. We've got to be, you know, again, you have to triage effectively, etc. So I have to say that, right? But if we've triaged effectively and they're still not getting better, and we're trying our best, which you guys, I know you do, and I know that the people I work with really do try hard, and that's why I'm inspired by working with you guys in clinic. I think it's amazing that if you're trying your best and they don't get better, maybe it's just not their time. But there is, you know, but if you're leaving the door open for them, that they might come back and go, you know what, Brandon, Romy, what you said to me on that day just meant something. And that, it just shows, anyway, how you said earlier, Romy, just one tiny experience, and she's literally changed direction.
Yeah.
Similar to what the people experienced I spoke to.
Yeah, it's really interesting to be with people and try to move forward when there is so much uncertainty about where the effect is going to come from. And one thing that I think I've learnt from you is, like you were saying earlier, you can't do everything in one session. And also another thing that you said that stuck with me is that you can't help everyone. And I was wondering how you managed that as a practitioner and how that's changed over the years, because it is something really hard to grapple with when some patients just don't get better.
My instant thought that comes into my head is with gut-wrenching pain.
Okay.
Like emotional pain, this is
Okay.
myself, right? I know, again, we spoke about it countless times. I'm an avid people pleaser. So when and I think the two biggest reflections I had from early days in treatment in osteo were that I can't help everyone and not everyone's going to like me. That was proper rib busting, oh. But when I come to terms with that, it was actually freeing, because all I know I've got to do is just try my best, listen to someone, meet them on a human level, blah, 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 blah. If they're not ready, they're not ready. And I can't force that. And for me, that was really, really freeing. It was hard, don't get me wrong, it's a process of people not getting better, people just not coming back, and going, oh, why did you not come back? Not getting, getting ignored, or, that for me, I found that really difficult in the early days.
Yeah, it's interesting that almost the practice of treating and caring for others is a treatment of yourself, to some degree. And I think that's something that we, especially going into this degree, is not ignored, but is not brought to light. Because everyone, I'm sure you did as well, through the process of this degree have had so many different either light bulb moments or moments of dips and loss of faith and all of these kind of components, and that's in yourself and in the stuff that you're doing. And so it's a really interesting process to have to go through.
The nightmare for me, Brandon, was then I'd have a light bulb moment, and this is when I was a student, thinking, right, I'm going to do exactly the same next week on exactly the same person, and then it collapses. I was like, what's all that about?
So many times.
It just showed, this is what I mean, this is that living in the uncertainty. And inherently, we don't like uncertainty. We want to know an outcome. Someone, when they come in and see us in pain, want to know the reason. And the evidence says that it's multifactorial. It could be many things. All right, it's, sometimes if they've rolled their ankle and they're getting pain in their ankle and all the tests for, lateral ligaments and all that sort of stuff, we can probably say it's like that. But with the back pains, the neck and shoulder pains,
It doesn't work like that, does it?
no.
Yeah, and maybe the most consistent technique, if we're going to talk in those terms, that we can use is being present and non-judgmental and doing our best. And maybe that is the tool that consistently will reap.
And I think being comfortable with
positives.
not knowing. That's a hard place to be.
Yeah.
Actually, was there a particular patient that that brings to mind with relation to that understanding? Did you have a particular patient that was suddenly changed your perspective on how you should conduct yourself in that respect of people pleasing and whatnot?
I think it was a process. I don't think there was one person.
Mm-hmm. No one that particularly brings to mind? No particular interaction, let's say?
What, a people-pleasing thing?
Yeah. Of understanding that you can't help everyone.
No, actually, I think it was a process through time.
Yeah.
And you know what? I think it actually come around in some of those recovery meetings that I observed.
Oh, interesting.
That you can't help everyone.
Mm.
And they can't help themselves.
Mm.
Or they can, they can help themselves if they want to be helped.
Mm.
Right. And I guess maybe that's a question of respect of the person and actually respecting that it might not be their time is also a form of respect. From
that as well, it's like, if the person's ready to change, they're ready to change. And how does that fit with people pleasing? It's not, I suppose it fits with perfectionism, right? That I want perfect results every single time. And that's impossible. There's no perfect.
So what kind of advice would you give to, I guess, us students? I can't believe we're graduating soon. We started this when we were in our first year.
That's a joke.
As if we didn't have any self-confidence already. Can't remember what I was going to say now. Oh yes, would you have any, I guess, advice for budding osteopath clinicians in terms of how to avoid becoming stale in your practice? Any ideas on that?
I suppose one thing I'd say, I suppose I'd watch social media groups. Really, really watch those. I think actually now they're becoming quite toxic. I think they're good because you get to see the spectrum of where osteopathy is, maybe. But I don't think it's alien to any. I think it's probably similar in all the other professions. We just obviously see it within osteopathy. I think it's, watch that.
Okay.
I think because for me, when I was kind of like learning, I was kind of quite taken in by people that spoke loudly. So, people that shout the loudest and all that sort of stuff, and be quite scared about upsetting people and all that sort of stuff. I'd say just be reflective. Even not, just that question is like, even those sort of questions, where do those ideas come from? Why are they strongly held, given what we know about pain and the person and anything else, that it's not that simple? I think be really critical. Read stuff you don't want to read that challenges your own views. Don't get caught in an echo chamber. And they're quite in groupthink. It can be really easy to fall into. Always reflect on your experiences. Fundamentally help each other. You your best, I think we're really lucky with the group we work with. I think on Friday, of course I would say that, but Fridays, I feel it's really kind of accommodating.
It's because you're here.
No, but it's not. It's nice. No, it's not. Of course, I'd love to say course, but it's not. It takes a certain amount of engagement through your students, and I think help each other, be critical of each other, be the practice educator. If someone says something a bit wild that you want to, that's really interesting. How did you come to that? Because I could say it, I can throw statements out and they think take it as gospel, and I think that's another thing as well. Where I expect you to display reasoning, I expect it. If you want to do something, I expect you to tell me how you can do it, how you've arrived at that. Partly, I genuinely find it interesting, how you've come to a decision. You should do the same to us. We expect it from you. If you're not understanding or don't agree with anything, just say that's a really interesting point. How have you come to that? You don't have to be conflicting. Conflicting. Just say, oh, Dan, how have you arrived at that decision? We expect it from you, so I think you should expect it from me.
Just applying clinical curiosity across all interactions.
Because that's what's going to happen when you qualify.
Yeah. And how do you envision the role of osteopathy evolving kind of in the context of this comprehensive pain management in the future?
See, this is my people pleasing coming in now. I can't say something that's going to satisfy all groups.
Good.
How do I see fitting osteopathy going forward? I think it has a large role to play. I think if people in the profession let it evolve. And for me, I suppose I see myself as quite a progressive osteopath, that I think research has a lot to add to our profession. But then in that, there's going to be some real horrible kind of reflections. But that's how professions grow. They reflect on their approach. They have those horrible discussions. But osteopathy seemed to have this, again, these are my views, they're my opinions. We really have this really strong held traditional belief about what osteopathy is. And again, I think Dave Nichols writes about it in some of his physiotherapy, where he calls himself a critical physiotherapist. I think we change with society, and if we don't move with society, I think we'll get left behind. But if we move with society, which I think we are, I think you pulled along with society, I think we actually have a lot to add, loads to add. That human, there's probably countless, I don't know actually, but there's evidence probably to suggest that touch is a good thing. It's a It's an evolutionarily supportive thing. And when done correctly and positively, it has the effect on people. I don't think we're going to ever lose that. But that's not just for osteopathy, right? Physios do that, chiros do that, sports massage therapists do that.
So what do you think makes osteopathy osteopathy? Do you think it is defined by something unique, or do you see it as a kind of one piece of a common, larger body of professionals?
I think that's probably individual to the person you ask. And osteopathy, for me, is probably just meeting that person where they're at, and then creatively applying myself to that person, not the other way around. So by that I mean the patient, and I struggle with it sometimes. The patient dictates it. That's not to say, they come in and, can you click my neck? And I say, yeah, no problem. It's not like that. It's mean that it's about drawing on knowledge that's going to help that person at that moment in time. That's why I love that creatively applied knowledge. It's not like, right, okay, it's lower back pain, so I'm going to follow nice guidelines, blah, blah, blah. Of course, I've got to have that as a grounding, but then it comes in, the creative, personal element comes into it. Yeah. But I don't even know if that's a definition.
It's a really, I think it is. I think it is.
But it's such a personal thing.
Yeah. And it's interesting to be able to work with so many different osteopaths as well. It's interesting talking about, I like what you said about read what you don't want to read, because you sent me a few papers and I've read a few, and there's also some where my brain has gone,
no thanks,
forgot about that. And I know that it's not forgetting, it's like a resistance that's manifesting as just, I forgot to read those papers. And I think it's really important to maybe have all the more an interest and a consistent practice in reading the stuff that you don't want to hear, because it will challenge you.
It might open your eyes to something. Yeah. It might unlock something that you never thought you'd understand. It might just be said in a different way from someone you didn't like, and you go.
Yeah, it seems to be a common theme just in life in general, that the answers that you're looking for are always in the places you don't want to look.
Yeah.
And so I guess you can apply that to this to be able to grow yourself as a practitioner and hopefully as a profession.
Yeah. Actually, you know what? Going back on your point, I suppose I should draw on one of my findings from my paper, right? So this is what someone who had gone through long-term pain, what osteopathy meant to them, or how they understood it, and the kind of sub statement was, osteopathy allowed me to feel connected to myself and another human being. And in it, this person said, it's the whole bedside manner thing, and I think plays a huge role. The fact that these two osteopaths genuinely care about my health and want to make my life better, that placebo effect, bedside manner, these things we know are real, and I think they work strongly for me. I really do, because it's a huge difference. They make me feel like I am worth the effort. I've always found that in osteopathy. But it is. And that's a person who couldn't get out of his chair, who was scared to get out of his chair.
Oh, that's our definition then.
But do you know what I mean? But I don't. What we've got to be careful of, that's not isolated to osteopathy, right? That's people in these type of roles want that. We want our patients to do something different and positive for themselves. Otherwise, we wouldn't do what we do. I don't mean.
Yeah. Oh, that's wonderful.
That's really lovely. And what are your kind of aspirations and goals for the future now that you've completed the doctorate, you've got the title?
Oh, no.
What do you want to do?
My wife asks me this all the time, and I give her a different answer every single time. I probably shouldn't have said that publicly, should I? I say to my wife, don't listen to that podcast.
Boring.
Yeah. You know what? I suppose that when I originally set out all those years ago, 6 years ago, I thought to myself, I want to bring health psychology into osteopathy. That was the idea. I think it's, whether we like it or not, we're working with someone's psychology. That was the idea. And I still believe that. And I still think, any other, especially with the multidisciplinary approach, MDT type stuff, that, like multiple teams and different professions, we should just be learning more of each other, right? But What's my aspirations for it? I suppose when I did set out to myself, I thought to myself, what would the ideal role would be? Okay, I'd be dual registered, so which I'm going for registration at ACPC. That should come through in the next few days. So I'll be a practitioner psychologist. And I remember going through the doctorate, and I was like, it'd be brilliant just to be that kind of sit there and say, right, we're going to do this, we're going to do that. Case history, and then there'll be talking interventions, there'll be manual therapy. As we love supervisors, they were like, I don't know if it's going to be that easy. I was like, what do you mean by that? And they went, well, if someone's, you take people with adverse child experiences and all that sort of stuff, right? Say, for example, I see someone like that and they come to see me as a psychologist, or they think they're seeing me as a psychologist, and then I do the case history and do that. All of a sudden I put my hands on their shoulders, right, with consent, and they go, what the hell's going on here? Or the other way, someone comes to see me as an osteopath and they don't get any manual therapy. They're like, it's not a talking session. Like, what's going on here?
Like, what are you paying for?
Exactly.
Yeah.
Or who do they complain to? So, like, if they're a bit unsure, like, which regulator do they go to? So, like, be careful with that. Ethically, it gets a bit challenging. I was like, I didn't think of that. So, I kind of changed tack a little bit. I was a bit like, well, maybe it's going to be, like, so I'll still practice separately as an osteopath, like I practice at Pure and I practice at Phoenix. Maybe now it's time to start trying to get some role as a psychologist, to really start developing myself in that area, because I've not actually had any intervention experience. So I want to get that experience, like exposed to it, a lot of it. And whether I don't think that would have to be in pain. It'd just be after people managing chronic health conditions, and then see how that works. Then maybe later on in life, see how that goes. Professionally, it might be like, okay, so you see me, I'll be osteopath, I'll be registered with both. Whether I see someone, this is how I've been thinking about it, see someone as an osteopath, but then on the outset say, right, there's going to be this amount of osteo sessions and this amount of an ACT intervention or something like that. So then they know they're getting an osteo. This is only theory, right? Practically, it's probably very different, but this is where I kind of start visioning it, that then the person knows they're going to get osteopathy for X amount of sessions, and then they're going to get an ACT intervention for X sessions. Or I see someone as a psychologist and then say, right, and what I'll do, I'll refer you to Brandon or Romy, who will help you with while you're going through your osteo, because we speak the same lingo. See that, and then I'll support you through this intervention.
That sounds so exciting, because even if it's not quite clear what form it's going to take, again, having that uncertainty in the unknown, I'm sure it's going to breed a balance that makes sense to you in some way, and you probably won't come to it directly, but I'm sure it will find its way, and we're so proud of you for what you've achieved.
Thank you.
I just wanted to say that.
Thank you.
I think we're going to leave it there for today.
Thank you very much for coming.
No, thank you for asking me.
It's been a real pleasure, and it's something we've been waiting around for a little while, waiting for the doctorate to come through finally before we begin.
Good timing.
Exactly.
Before that, your opinions don't really matter.
Yeah, that's fair.
But finally, I'd just like to say thank you very much to the UCO for letting us use this premises to record this episode.